to talk about the modified technique of nasoalveolar mold, named after Dr. Teresita Panacci and Dr. Barry Grayson. The functional maxillary orthopedic treatment was first described by Dr. Teresita Panacci in 1997. And she followed the technique of McNeil. This is not new. Dr. McNeil started with Presurgical Orthopaedic in 1950. And Dr. Grayson added the nasoalveolar molding to the plate, to the obturator plate in 1993. As Dr. Kernahan, a plastic surgeon, says, in 90, a cleft repaired is evident more by the nasal deformity than the lip repaired. And this, nowadays, it's totally true. So let's review some of the anatomy of a unilateral nasal cleft. As described by Dr. Donald Mackay, says that the lower alar cartilage, please see the picture, the cartilage on the cleft side is depressed and concave. It's the medial crura, which is the inner part of the lower alar cartilage and conforms the columella, is also depressed, falling down, and it's separated from the medial crura of the contralateral side. And that makes the tip of the nose fallen, displaced, and there is also a resultant overhanging of the nostril apex. The columella is inclined with its base towards the non-cleft side. In this patient, this is a 3-month-old patient referred to our clinic by the plastic surgeon to have the presurgical orthopedic treatment. And at the first appointment, this patient had an angle between the columella and the base of the clefted nostril of 80 degrees. Anatomy of the unilateral cleft palate consists of 2 segments. One segment is a cleft maxilla or minor segment, which is deficient and hypoplastic. The anterior nasal spine, the premaxilla, and the rectum are deviated towards the large segment or non-cleft side, and they are procline and or vestibularized. At the first appointment, this patient showed an alveolar cleft ridge of 11 millimeters. And its anterior-posterior difference between the big segment and the small segment was 5 millimeters. Okay, this technique consists of 2 stages. The first stage is the functional maxillary orthopedic plate, or FMO plate. And it consists of an acrylic plate placed inside the mouth of the baby as soon as possible. Better if it is placed the day that the baby is born, or at the 8 days after birth. In this patient, we started at 3-month-old, a little older, but it still works. The main goals are to model and remodel the alveolar bone, promoting the bone growth and closing the gap. And with this, we would give the soft tissue the skeletal support needed before the primary surgery. We will also give the patient a U-shaped maxilla by aligning the maxillary arch. And of course, one of the main objectives of this first stage is to give the baby a functional occlusion even during the primary dentition. Another goal is to give back the baby the basic functions to thrive, which are breath, suction, and swallow. And the most important thing of this stage is that it accompanies the fascial growth through the normal position of the tongue, which is extremely important for the development of the mid portion of the face. The physiological basis of the first stage are the growth theories published by Dr. Enlow in 1965. The functional orthopedic plate causes intermittent touches, as we can see here in this Let me see if it works. Sorry. There. This is the way the plate works, by intermittent touches to the palatal surface and movements. And these movements are around 1,500 during the day. These bone changes occur throughout the whole life, even in older ages. And these are the modeling and the remodeling of the bone. By modeling, we are provoking a translation of the bone because the bone is adapting to these biomechanical forces. And by remodeling, the bone is relocating by the awakening of the osteoclasts that remove the micro-damaged bone, and then the osteoblast will give new bone or form new bone to preserve the bone strength. So the mechanical adaptation of bone to forces is the physiological basis of this technique, of this stage. Well, the protocol. We have to start first by taking impression. We take the impression with the patient awake with alginate, as I said before, as soon as possible. When you have taken the impression, you have your plaster cast. You design what is the best design for the case, because every case is different. And once you decide, you wax and scrape on the plaster cast, depends on when you want the bone to model or remodel. And when you have that done, you manufacture the FMO plate with hard acrylic. The treatment protocol goes from the first month of life. We change the plate every 15 months. And from the first year, we change the plate every 30 days or every month. And from the first year to the second year, before the palatoplasty is performed, we change the plate every 2 to 3 months. And by saying changing the plate, I mean that we take a new impression every time. We do the design every time, and we do the waxing and the scrapping every time. The second stage is the stage of nasoalveolar molding. This would allow the surgical repair of the nasoalveolar molding complex with successful aesthetic results, and that'll make your plastic surgeon very happy. The main objectives of the NAM is to mold a dome shape, lower alar cartilage, to lift the tip of the nose, to straighten the inclined columella, narrow the base of the affected side, and correct the position of the philtrum. Please note that one of the objectives of this stage is not enlarging the alar cartilage. We don't enlarge the alar cartilage. In this patient, the nasoalveolar molding was placed once the cleft had reduced to 6 millimeters. Remember that he started with 11, and 2 months after using the FMO plate, the patient had reduced the gap by bone growth to 6 millimeters, and that's when we place the nasal stent. The nasal stent consists of a rounded 0.7 stainless steel wire bended as a gooseneck. And on the top of the gooseneck, we put some hard acrylic and soft acrylic and do the activations weekly. When the NAM is activated by soaking and taping, temporary cartilage ischemia is seen. It's very important to underline that it's temporary. If it's not temporary, you're going to cause damage to the soft tissue, which is not good for the surgery. And the upward pressure causes increased columella height and decreases the inclination, in addition to raising of the tip of the nose. And every time the patient suction or swallow, NAM is activated. And that is why we don't recommend and we don't use any type of prosthesis adhesive to use with these patients in any of the 2 stages. So we add soft liner on the top of the stent. so that the tissue, as I said, breakdown does not occur. We cover the tip with acrylic, giving it a kidney shape every time. And do not bend the wire to activate the nasal stent. And that's important because once you bend the wire loses its rebound motion and it hardens. And so it's not going to be as elastic to promote that intermittent touches to the alar cartilage. The nasal stent is always placed in the middle, parallel to the midline between the labial segments. And throughout gradual addition of acrylic, the kidney-shaped stent is positioned under the apex of the alar cartilage on the cleft side. The superior lobe enters the nostril and presses up and forward against the nasal lining behind the dome of the alar cartilage, and the lower lobe is positioned under the apex of the nostril aperture. The soft acrylic is placed on weekly activations to the kidney shape that goes into the alar cartilage in order to avoid lesions due to pressure, and the lower alar cartilage lays on the groove between both lobes. The appliance, as I said, is changed and redesigned every 4 weeks. The results, we measured the results with following Dr. Masseri's protocol published in 1971. The functional maxillary orthopedic promotes and accompanies the maxillary bone growth in 3D way. As we see in the table over there, this LX means alveolar ridge cleft width. With MM, with little mm, is the palatal middle cleft width. The TT is the cleft width at the tuberosity, and the GX is the anterior-posterior distance between the large segment and the small segment. So we take we take a photocopy each month of the casts, and we do all these measures to see how our treatment is improving the case. And this serves a lot to motivate the caregiver or the parent, because once the parent and the caregiver sees that it is working by bone growth, they get so excited that they are more committed to use the treatment. These are the results of this patient. The alveolar ridge started with 11 millimeters, and the 7 months after starting the treatment, before we sent him to the primary lip repair, he had a 3 millimeter gap between both segments. And the anterior-posterior difference was 5 millimeters at the beginning and 1.5 millimeters at the end. But the most important thing I want to underline here is the capital M's. The capital M's is the total growth of the maxilla in the transverse plane. And you see he started with 40 millimeters. And by the time he went to the primary lip repair, the maxilla had growth 7 millimeters on the transverse plane. And this is important because one of the most one of the most, I don't know how to say that, sorry. One of the most difficulties for this technique is that sometimes they say that the maxilla is collapsed. And it won't grow, but it's not, with our technique, it's not true, because we're changing the plates every month and we accompany the growth of the baby. So the other difference of this technique is that this technique works in the 3 dimensions of the space. And I want you to see this video. I'm going to, we took some CAD-CAM images of this patient, so you can see how it's working in the 3-dimensional planes. And because you're going to see how at the beginning both segments were not aligned and labeling, and at the end, after the caloplasty, they are completely labeled. Let's see. I'm sorry. So now we can see in the pictures how the bone is covering and closing the gap, and with no suffering of the transverse growth of the maxilla. This is how the patient was growing, like this, and the patient before or ready to be sent for a palatoplasty. The results of the second stage of nasal molding. The unilateral patients are always having the cleft segment longer than the other side. So in the picture that is to your left, I think, the cleft side nostril doesn't seem longer than the other one, and the alar base is narrow, and the philtrum on the tip of the nose are positioned towards the midline. The lower alar cartilage of the cleft side has a dome shape. The columella is longer and straighter, with an angle to the alar base on the cleft side of 90 degrees. And this is my what I help in this technique is that the time that the columella has a 90 degrees angle to the base of the clefted nostril is the time when I send the patient back to the plastic surgeon to have the lip repair. The tongue position is down, and that's important. If you see, the tongue position is down even without the use of the plate, and less deviation of the nasal septum is seen. So for conclusions of this technique is that the benefits are the normal mid-face bone growth, more natural and aesthetic profile in both sides, easier surgical repair with less scar due to the less of tissue tension and less need of extended dissection during surgery. And the most important thing is that no adverse effects are done to the maxillary bone growth in any plane of space. The recommendations are that we continue using the orthopedic obturator until the palatal repair is performed. Even after the caloplasty, we keep using the first stage or the FMO plate. And that close follow-up of the patient and caregivers have been shown to be crucial on preventive carious lesion, even in adverse environment, and this is very important. This is the patient 1 month after the surgery and 1 year after the surgery. And this is the pictures underneath are when he first came to the clinic, and this is the result of the patient. But I would like you to see the basal picture when you see the hypoplastic maxilla on the cleft side. But when you see at the end, 1 year after, the patient has a normal mid-fascial growth, and the profile is even a little bit protrusive. We can get the functional occlusion that we were looking for by putting the midline of both arches coincide with each other. There is a very nice U shape of the arch, and primary teeth are able to erupt on the cleft. There is the alveolar segments are completely approximated to the incisal foramen, and there is less probability of palatal fistula after the palatal repair. Now the patient's ready to be sent to the plastic surgeon for the palatoplasty. And just to finish, because my time's up, the two more powerful barriers are patience and time. Great achievements take time, and there is no overnight success. You have to have that in mind. Thank Thank you very much.